Dr. Tom George, the head of intervention radiology. Can we put our hands together and welcome Dr. Tom George?
Good morning, all. Yeah. Thank you, Dr. Jacob sir, for that kind words. So each time Dr. Jacob sir tells me, can you discuss a different topic? Like I'm actually stuck because what I should discuss, what we should discuss in our quest should be something new, but at the same time which is understandable and which is very much clinically relevant, and what each of us would be facing through our day in and day out, which because we are from the medical fraternity, your relatives, your colleagues, many of them will be bombarding you with so many questions. So thank you for highlighting about the varicose point, because there are so many unscientific methods. People might be you yourself would have heard about different methods of treating varicose vein. So you should be you should be up to date, and you should be updated, and you should know what are the best and effective treatment methods for varicose veins. So without wasting any time, let's start the discussion for today. So interventional radiology, about the specialty per se, like sir mentioned, it's basically it's a pinhole treatment methods, where it's essentially a scarless technique, where without much stay in the hospital, you go home the same day or the next day, and without involving any major anesthesia. So it plays a very crucial role, especially in the case of venous disease. Hopefully, in the future discussions, we'll be discussing about other parts of venous disease. So the specific entity we'll be discussing today will be about the varicose vein. I hope my voice is audible. Yeah. Okay. So especially in venous disease, there have been certain surgical techniques which have become obsolete now. So coming to our discussion for today, so basically what we will be highlighting is about what are varicose veins, the few basic concepts, how do you diagnose, how do you classify, and what are the usual treatment options we have available, and few specific relevant cases which we have done at Believers. So varicose vein, this is a picture from one of my patients. So if somebody asks you, especially our undergraduate students are also here, so varicose veins, what are varicose veins? So basically they are dilated, tortuous and long veins, and they essentially exist due to the non-functional valves. So if you see this patient, you can see the tortuous vein, how you can see the dilated, tortuous and long veins. So that's what are varicose veins, and what are the causes, and what for varicose veins. These could be congenital or acquired, and there can be many congenital syndromes associated with the varicose veins, or this may be primarily acquired due to prolonged standing, or which can develop with chronic straining, or which can be occurring in secondary to something else. Like some patients, some of your relatives may tell this triggered or this worsened during the time of the pregnancy, and so and so. Or we should always have in our mind there can be an underlying abdominopelvic tumor, which could be a secondary cause of varicose veins. Even though it's rare, that also should be in our mind. And what is chronic venous insufficiency, or CVI? It's a very common entity, and which essentially reduces your quality of life. And what happens here is the flow of superficial or deep veins, they are impaired. And usually if they are not treated adequately, they may be progressive, and they can lead on to post-phlebitic syndrome and venous ulcers. So varicose veins, as you know, as you can see in this picture, so this is how the normal vein is. That is, especially when you stand, the flow of the blood should be from below superior, from caudally to cranial and towards the heart. So only that flow is possible if the valve, there are some mechanisms like valves within the vein which should be functioning properly. But so if the valves are damaged, as you can see in this diagrammatic picture, that it may be tortuous, and valves can be deformed, and that leads to stasis of the blood. And what are the common veins of the lower limb? These can be superficial, deep, or perforator veins. So superficial veins, most commonly, this can be saphenous, great saphenous, or short saphenous veins. There can be other superficial veins, or there can be deep veins, like that all of us must be familiar, like the common iliac vein, which continues as external into the limbs, like femoral veins, popliteal vein, and deep tibial veins. And there can be some connecting veins between the superficial and the deep veins. As you can see here, there can be a deep vein or the superficial vein. So the connecting veins, these are called as a perforator veins. So any damage, any issue in these points can lead on to the varicose vein abnormalities. And I'm not going into the detail of the venous anatomy because we lack of time. And like I told, there can be deep veins, there can be superficial veins, and the connecting named veins, which could be perforator veins. I'm sure we all must be learning in our Bailey and Love and other discussion during your undergraduation. So as we already saw, the risk factors for varicose vein is increasing age. There can be your relative or like some patient might come and tell you their family also they have similar history of varicose vein. We might see, like you can see it may be associated with prolonged standing in various occupations like traffic police or like surgeons or other occupations, teachers. These all are increasing risk factors. So there can be various nomenclature, various kinds of terms you can hear in varicose veins, like spider vein, reticular vein, telangiectasia. There can be patients who present with various skin manifestations like hyperpigmentation, eczema, as you can see, the inverted champagne appearance, which is called as a lipodermatosclerosis. So these are all the different ways patients can present. There may be some hypopigmented patches in the skin. This can be because of the pre-existing ulcer, which is healed, leading to scarring. This is called atrophy blanche. And I'm not going into the detail of the pathophysiology because already we have discussed. So basically, this is how a healthy vein should be. So when the vein is damaged, you can see the flow of the vein will be, actually it should be from below up, but because the valves are damaged, the blood pools in and that leads to venous hypertension. And there can be various kinds how you can classify the clinical manifestations, how the patient presents with you. So one of the common methods we use is a revised CAAP classification, CEAP. C stands for the clinical classification, E the etiology, and A the anatomical classification, and the pathophysiology is P. So if you, because this is to standardize the nomenclature when the patient presents, if the patient has an atrophy blanche, he is C4. So in that way, it is standardized world across. And depending on the clinical severity, there can be venous clinical severity score also. And now, what are the common symptoms the patient presents with you? So the symptoms can be varied. So it's very, patients can present with just a leg edema, or there can be a dull aching or a aching heaviness. So usually these pains will be like towards the end of the day, and patients will usually give you a history if you ask. When you elevate the limb and keep over a pillow, he or she gets a relief of the pain. And the signs, the patients might tell you there are prominent veins, so there can be visible telangiectasia, varicosiform veins, like we saw in the initial picture of the patient, dilated tortuous veins, and associated extensive skin changes can be there, and you have to look for ulcers. So ulcers, usually it has a typical presentation in varicose veins, that it will be usually at the level of malleolus or above. Usually you don't see like near the web spaces or the tip of the toes. So it's very important to pick up the sign because there are other diseases which can like mimic the varicose. And how do you diagnose? The Doppler ultrasound is very crucial. At the same time, it is very important to rule out a deep vein thrombosis. So the deep veins have to be patent. Even if you're planning to manage or treat the varicose veins, it's very important to document and identify that the deep veins are patent. And like we discussed, the perforator is something which connects this diagram very very nicely describes how a perforator should be. So like we told, the deep vein, there's a superficial vein. So the skin is here, so the vein is very superficial. So the vein connecting the perforator. So normally in the perforator vein, the blood should flow from that superficial to deep and from there to the heart. So if there is any incompetence, so the flow is defective, the perforate, the blood, instead of going into the deep vein, the blood goes and stays in the superficial vein. So that's a perforator incompetence, the different Doppler findings. I'm not going into the detail. So now coming to what all you are all waiting for, that basically the treatment methods. So, and patient selection is also crucial. So there exists a lot of, apart from the like quackery, there are a lot of other scientifically established, well established treatment methods that exist in the varicose vein. Few of them are like, and like day by day there are more updates happening, and there are more changes of the treatments which are happening. So these are the various treatment methods which exist in the treatment of varicose veins. So what we will be discussing will be mainly pertaining to the endovascular or interventional radiology like treatment, which is other than the surgical treatment. And we'll be, if time permits, we'll just quickly see about the ulcer management also, which is also very important. So so these are the few methods we'll be briefly seeing, the treatment methods. So initially, not all patients need an aggressive treatment. The initial, for the mild symptoms, the patients might need only conservative management. That is basically you have to ask the patient to elevate and keep the limb whenever they take rest, and probably they can frequently change their postures. There can be usage of compressive stockings. And there is some medicine which been prescribed along with that, Daflon, which also has some benefit in reducing the portal pressure and reducing the inflammatory changes. And usually the dose of Daflon can be 500 or 1000 1 gram. And along with that, some skin emollients or skin solution may be given, like moisturizer, which can help in giving some skin soothing effect. So you should not be like, there can be some patients, patients who might come and tell you, like, doctor prescribed skin ointment, a skin solution, lotion, and then her symptoms like vanished. You should understand that in varicose vein, unless you treat the underlying cause, the symptoms or this can recur because the applying a lotion or solution is just to give a temporary relief to the skin. Maybe the skin irritation, all those things can reduce. And all of us must be familiar with your relative or somebody coming and tell you varicose vein, എനിക്ക് varicose vein ഉണ്ടായിരുന്നു, അട്ടയെ കൊണ്ട് കടിപ്പിച്ചപ്പോൾ ആ blood പോയി, അപ്പോൾ varicose മാറി. So and all kinds of these things they'll tell you. So because then very the people, the quacks, they actually literally take your confidence and tell you, because they'll tell you that ashuddha raktam mati and attaye kondu kadippichu. So basically what is the point? It's ashuddha raktam means an impure blood. So it's a venous blood is always impure, it has to be oxygenated. But once you suck out the blood, definitely the blood will keep on coming. So there is no scientific basis for those things. So you should actually, in a very polite way, you should tell them and try to, if it's your relative, you should tell them, go and get the best treatment option. There's an issue with this, and it's not scientifically proven, and all those things. And so like we discussed, the conservative management involves compression stockings and replacement of the stockings should be like ideally replaced every 3 to 6 months. And coming to the next treatment, there's an endovenous form sclerotherapy. So basically, the basic concept is basically there can be dilated varicose veins in the skin or spider veins. So what we do is we inject a solution. It's a sclerosant liquid or a foam. We inject into the varicose veins. So basically, after that, what happens is that dilated varicosiform veins, they undergo sclerosis and they shrink in size, and patients' symptoms get relieved. So there are different positions and for all like approaching different kinds of veins. So if it's, for example, if it's a right great saphenous vein, patient has to be pushed in the right lateral position. And how do you usually administer? It's usually done through a IV cannula or a butterfly. And how do you prepare it can be prepared given as a liquid or a foam. So you can see in this video how we prepare for foam. So if you see both syringes. So there's nothing in that syringe. It appears like a transparent. So once you mix the solution, you can see the sclerosant is being formed. So that is how a foam is. I'll just show you once more. So that's how a foam, a sclerosant is being prepared. That's how what you administer. and it may be available in different concentration. Different agents can be applied like cetrol, which is available from 0.5 to 3%, polydocanol. Each have its own advantage or disadvantages. And what after giving a sclerotherapy is the part of a doctor and as a patient, and what he or she should understand. Along with that, it's very important to wear a compression stockings at least for 3 months, and maybe in the initial 1 week it will be crepe bandages followed by compression stockings, and if there are associated ulcers, there will be double layer stockings which is needed. And sclerotherapy usually has it's a safe procedure. It may be having some minor issues like skin staining, or patients can have some pain, throbbing pain, which may be transient. Major complications like DVT, pulmonary embolism are not very, very rare. So this is something which we are not discussing. That is, it's another modification which had come in varicose vein treatment, which is called MOCA. MOCA basically means mechanochemical ablation. Just have in your mind there is something called MOCA also. There are different techniques where we combine mechanical and sclerosant agent to achieve better results. So it's called, one of the technique is called phlebograph, another technique is called Clary-Vein, and is another one of the most established, which has significant literature and supposed to be very successful, one of the successful treatments, which is called the endovenous thermal ablation. So endovenous thermal ablation, which can be done via using laser treatment or a radio frequency RFA treatment. So what we do in laser and RFA is basically all these are essentially non-surgical. So basically you make a pinhole, just a small opening in your leg at the site where you enter the affected vein. So what you mean as an opening is just 1 or 2 millimeter. You can just imagine 2 millimeter opening just through a pinhole, and we enter using a catheter, RFA, radio frequency ablation catheter, or a laser fiber. We enter and we reach up to the affected vein. Let's assume if it's a great saphenous vein which has to be ablated. Ablated is basically thermal energy. You give thermal energy and ablate and shrink the vein. You reach up to the great saphenous vein, reach up to the common saphenofemoral junction, 2 or 3 centimeters away from saphenofemoral junction, and you ablate. So it's very important once you, and before starting the ablation, it's very important to do under mild sedation so that the patient is comfortable, which can be done using femoral nerve block or a conscious sedation. And along with the, and usually for femoral, laser or RFA, we don't go from the medial malleolus. It's usually preferred from mid-calf or above. And before ablating, the catheter reaches from the inferior level up to the saphenofemoral junction, and along the vein which is to be ablated, it has to be adequately given tumescent fluid has to be administered, and the vein has to be protected. I'll just tell you what is the benefit of tumescent anesthesia. This in fact reduces the pain and makes the patient more comfortable, and it avoids an unnecessary thermal damage to the structures adjacent, and helps in reducing the vein, and so that the ablation is proper. And after the procedure, patient is usually given compression stockings and early ambulation. We don't want the patient to rest for 3 or 4 days. So if it's a mild sedation patient, we immediately mobilize in 1 hour. If some cases we do local. So immediately patient mobilizes. So that in fact helps avoid the complication of deep vein thrombosis. And patient will be usually on antibiotics and analgesics. And rare complications which we have to watch out for is a deep vein thrombosis. Accidentally the clot can enter the deep veins. So it's very important you see every step under ultrasound where you ablate and how you pull back the catheter. It has to be away from the deep veins and like a couple of centimeters away from the saphenofemoral junction if it's a great saphenous vein which is ablated. Other complications are like injury to adjacent nerve and thrombophlebitis. And patient has to be followed up. There are different protocols. What we usually follow at Believers, what I usually follow is, first I call patient after 1 week, then after 1 month, 3 months, 6 months. And usually patients give their relief of symptoms, and the same thing can be objectively assessed on Doppler. And usually what the technique we use is segmental pullback technique. And coming to a patient who presents with you an ulcer. So this is one of the patients who came to our OPD recently. So actually the patient is telling, patient had since 1 year, patient is having this ulcer. But I was in fact thinking of how can you be so irresponsible of taking care of your health. So, but patient told her husband is having stroke and so many family issues, which is understandable. So ulcer, so you can see how bad the ulcer is with associated skin changes. And I usually take, if I have any concerns, any doubts, I feel free and I take the opinion from my dermatology colleagues. They, if any swab has to be taken, that we'll be sending for microbiology and to prove and so. And so you have to be watching out, and the ulcer healing, ulcer care has to be extremely careful. The management. We usually like do a local debridement, the multi-layer bandaging, which can be 2-layer or 4-layer bandaging, and other causes of ulcer has also to be ruled out, and the dressing has to be changed adequately in order to prevent any soakages. So now coming to the most interesting part, like basically the few cases. So due to lack of time, we will be seeing only few cases. So these are all cases which I have done, which are my patients done at Believers. So you can see, these are all patients which we face and which you all must be facing in your day-to-day life. So the first patient, the 34-year-old male who has been complaining of dull aching pain over left lower limb since 5 years, the young patient, and clinical examination and Doppler evaluation was done, which showed saphenofemoral junction incompetence with associated multiple superficial varicosities and incompetent perforatus in the leg. So this is a patient's clinical picture, and so the patient was suffering a lot, and we discussed the patient with the patient about the different, with his wife also, different methods of treatment, and they decided, and we decided to go ahead with the endovenous glue treatment. And glue, as I'll just tell you briefly about glue. So it's a painless, totally painless procedure which can be done under local anesthesia. It's a daycare procedure, and patient was immediately mobilized post procedure. It's called as an endovenous glue treatment. So glue essentially, like the word suggests, it's something like a sticky substance or like a Fevicol. So basically you introduce through a catheter, like through one point of the vein, and the tip of the catheter extends up to the point where you have to treat. Then slowly you pull back the catheter, and thereby you administer this glue. So every step, like I told us, visualized under ultrasound guidance. So this is the patient. Then I'll just show the post-treatment image. Patient came, like I told initially, after glue we'll be applying crepe bandages, and we'll ask the patient to come back after like 4th or 5th or within a week time. So this is when the patient came on the day 4. The same patient. So I'll just show the pre-procedure image of the same patient. This is just on day 4. So this is, and patient, even if and obviously the patient's symptoms have like immediately vanished, and so like I told, the day 4, and patient was extremely happy, obviously, because of the symptoms are disappearing, and like all the veins, everything disappeared. This is another picture of another patient who underwent endovenous glue treatment, just to show you the pre and post procedure images. Very safe procedure. And similarly, this another, like we discussed, is EVLT, or it's called endovenous laser treatment. It's a purely non-surgical method, where you can see this is a laser. During the laser, when the fiber is on, you can see the laser light. So same way you can see, you approach the puncture point. This is just a single puncture point we approach, and we ablate and use the segmental pullback technique. And this is another patient who underwent laser treatment, pre and post treatment. This is all the skin changes, which will take usually some time, but the varicose veins, everything has disappeared. Patient is doing good. So this is this is an interesting case. Basically, so 42-year-old Mr. M, he presented with the aching pain in the left leg since 3 months, with a lump-like sensation behind the knee, and its pain was like very severe at times, preventing him from sleep. And patient, in fact, gave history. He had bilateral varicose vein disease. He had undergone multiple treatment sessions, but the curious thing was the patient, the site where the patient had pain, the left side. Only recently, patient had undergone treatment, like around 6 to 8 months, and it was done in a so-called one of the best varicose vein centers. We don't expect the recurrence immediately. When patient was complaining, there is a lump-like sensation above the knee. So and we had done it. The patient came with a Doppler finding, and Doppler did not show anything because obviously recently the laser treatment or the treatment was done. Obviously the veins were all okay, just few superficial varicosities, and we did a Doppler. So I do a Doppler for each of my patients, because unless you do a Doppler and do a proper mapping of the anatomy, it's like futile to do a just because like there's a Doppler finding based on that. If you do, because there can be so many variations in the varicose veins, and you need to be aware of that, and like something in this patient. So basically when I did the Doppler, everything was fine, but the side where the patient is telling the complaint, I could see a large dilated vein. So it's connected with the superficial vein. It's actually above the knee, so usually this is not a common finding. So possibly that's why the Doppler didn't also was missed, and it was left untreated. So it is a vein connecting the superficial vein to the deep vein in the popliteal region. And you can see in the image that's actually a reflex showing a perforator incompetence. So we took up the patient. So this is during the procedure. So you can see the patient is lying down in a prone position. So every step we are visualizing under ultrasound guidance. So this is somewhere just above the knee. So we approached the vein, and patient underwent endovenous laser treatment under local anesthesia, and patient got discharged the same day. And I'll just show you. I hope you'll understand this. The image may not be clear, but you can just see that basically the laser fiber is here. You can see once the laser is on, you can see that echogenic cloud being formed. So that is how you see on ultrasound the laser being when the laser fiber is on. So the patient was again the patient came after follow up after 1 week. His complete symptoms, including the lump sensation, also vanished. So this is the post procedure follow up Doppler. This is the same vein. You can see now it's all thrombosed. The size of the vein also is reduced. For your better understanding, I'll just show you the pre-procedural image also. So this is the same dilated vein with flow. The flow is Doppler doesn't show any flow, and vein is thrombosed. Obviously, that was the cause of his symptoms. Patient was elevated of all of his symptoms. So this is something what is called as a perforator ablation procedure, PAP technique, or transluminal occlusion of perforator, TRLOP treatment, where you access the perforator and ablate. And obviously, like this is another technique, say, like we discussed, endovenous sclerotherapy. You can see the sclerosant again being formed. Like this is how we make the form sclerotherapy. And there's a patient, 50-year-old lady, done like 2 weeks back. A patient came with dull aching pain over cough, no ulcer or history of any bleeding. So this is how we do form sclerotherapy. We discussed already endovenous thermal ablation. We discussed about endovenous glue treatment. So this is our so we usually, like I showed, apply by using a butterfly or a cannula. We can do so simultaneously. We can treat 1, 2, 3 cannula is being like a butterfly needle scalp vein is being kept. And you can see for a better understanding. And so we simultaneously we give sclerotherapy, the sclerosant what we prepared in the what I showed in the previous slide, and after that we just apply the small dressing. There won't be anything because it's a very small scalp vein, but just temporary relief for pressure effect, we just applied small bandages which will be removed immediately. Patient was put on like crepe bandages, and patient is doing extremely well. So this is another patient. Yeah. So this is a little elderly patient with history of bilateral varicose vein. So patient has undergone treatment from 1985 to 1990 onwards. So that is when his surgical treatment happened. Then after few years it recurred. Then he went to some center, did laser. Then he went to some center, did RFA and all those things. So we get a lot of recurrence and other referrals from other hospitals. So, so basically now this patient himself has come to our OPD with non-healing ulcer near both angles. So you can see, I'm not sure whether it is clear. So this is one ulcer here, there's another ulcer in this leg. So I'll just zoom the image for you. So I hope it's clear. So this is how the patient has come with ulcer in both legs, non-healing ulcer. Patient has been applying oil, all those local solution, moisturizer, everything. He has consulted many surgeons, many doctors, and they have given something, but his ulcer, everything is persisting. So after doing my my own Doppler investigation and following, applying, giving the what we did is giving a 4-layer bandaging, and this is when the patient came after 3 weeks. So there are some signs of healing showing in the right leg ankle ulcer. The left ankle ulcer is slowly, like it's almost clearly like significantly reduced in size. I'm not sure whether it's clear for you. This is the same corresponding ulcer of the same patient after 3 weeks. Then the left ulcer significantly healed, but the right ulcer was persisting. It's also showing the signs of healing, and this is how we do a 4-layer bandaging, and usually there can be a 2-layer bandaging for ulcer. This is my staff holding like during the process of applying the 4-layer bandaging, and wound care is of utmost importance. So when the patient came on follow-up, you can see this is the second stage ulcer. Like that ulcer is slowly reducing in size, and it's improving, healing, and this is finally when the ulcer completely healed. Along with that, it is very important to treat the underlying cause. The patient underwent endovenous sclerotherapy also, and patient is doing good. So this is another same patient, the right lower limb ulcer, just showing you the ulcer change, slowly healing, finally healed ulcer. So just to finish the cases, we'll have just a small quiz of showing it's another patient who presented with long-standing varicose veins with a skin lesion over left lower limb. So this is another skin lesion which we already discussed initially. This is the hypopigmented patch that's called as a atrophy blanche. So along with this, we had some concerns of the skin lesion, basically some pustule kind of appearance, infected. So I took my opinion of my dermatology colleague also. So we took a pus culture which is shown Staphylococcus aureus. Severe patient is currently undergoing antibiotic treatment, following which we'll be planning for a definitive endovenous treatment. So to conclude, minimally invasive treatments which are essentially scarless and sutureless. So you should understand the benefit of the treatment. It's essentially scarless. So patient goes home same day or the next day, no need for any rest, immediately goes, and he or she gets an immediate relief of symptoms. And usually if it is performed by a trained specialist, endovascular specialist, we don't see any major complication. Patient has to be on proper follow-up, and usually these procedures are done on daycare basis. And having said all those things, this is not just a one-man show. It needs a proper trained team, your colleagues and your nursing staff, everybody are important. So it's essentially a teamwork. Thank you.
Thank you, dear Tom, for that brilliant exposition of the recent advances in varicose veins therapy. If there are any questions, we'll quickly take a few questions before we... Yes.
Thank you, Tom, for the excellent presentation.
You,
so when we were trained, we were all trained with only the surgeon as the main role in management of varicose veins. So is there a modified schema or an algorithm where we know which is the patient? Almost seems like interventional cardiologists have taken over cardiac surgery in many ways. No? Now angioplasty is almost standard, and then there's a very clear role for bypass. Where does a surgeon come in the flow, and where is you? Or do we refer everybody first to you? That's what I'm wondering.
Definitely, to answer your question, you should understand the science is rapidly progressing. So earlier, whatever open surgeries what we had, these are all being many of them we can still do via pinhole treatment or a keyhole surgery. So but still the open surgeries, there can be an option possibly. What we can do is possibly you can send if you have any patients, you can refer the patient to an endovascular specialist. You can refer the patient to me. Maybe if there is any specific wound care management or something we need, for the ulcer patient, when we had to wait a lot. We had to be patient for one side, few months. In between, we thought the wound was secondly getting infected or something. Then I took one of my surgeon's opinion also, whether it's infected or not. So otherwise, for treating varicose vein per se, because there are so many advanced endovascular treatment, endovascular treatment which has a occlusion or a successful rates, showing there are many studies which are showing slightly the occlusion rates or the success rates are definitely slightly above surgery or comparing to surgery. So ideally the endovenous treatment, you should say it is taken over the conventional surgery is what I think what answer I should give you. But if there are no facilities for an endovascular treatment, obviously it may not be available in all the peripheral centers. Then I think maybe a surgical option, which is it's not a bad thing.
So in the spectrum of varicose veins, is nothing which you cannot handle, technically speaking, right?
Yeah,
Nothing which should be straight going to the surgeon, right?
Then other thing is like a superficial, very large vein. Sometimes there is something called as a microphlebectomy. So that is these patients can be offered as an endovenous treatment, or option of putting a nick. Like maybe patient will have multiple cuts, and then the vein can be completely taken out also. So that option also can be given.
Sorry, last question. Have you seen any complications? I'm worried about those major complications of DVT, stroke. I'm worried, no, when I send for this thing, which will suddenly embolize somewhere. And one second thing is approximate cost. These two.
So basically, that is just for when you discuss a minor and major complication. Just for completion, we usually discuss about this major complication. But in real life scenario, the deep vein thrombus does not, and the stroke, all those things does not. It's very, very extremely rare. I would say because why? Because every step, like in endovenous laser or glue, every step we are visualizing under ultrasound guidance. And for example, in glue, we compress, we start the glue or laser treatment or RFA from like few centimeters proximal to the saphenofemoral junction. So, and we compress and we proceed, we pull back and come back. So there is literally no way how the embolism, all those things can happen if it is done in a proper technique. But having said that, if you do not very careful, the glue is notorious for getting embolic. If you start your embolization starting administering glue from the deep veins, it can cause the immediate thrombosis, and it can embolize distally. So you have to be extremely careful. That is another thing. And laser also, if you are not very careful, so you can damage the nerves. Skin burns can happen. Deep vein thrombosis can happen. And even sclerotherapy also, in our experience, it's a very minimal quantity what we see. So we can actually, patients theoretically can have some sclerosing entering the deep veins, but clinically relevant thrombosis does not happen in sclerotherapy. And about the cost part, the thing is with early recovery with advances, definitely there is the expenses of some procedures will be on the higher side. But we should always compare it with your quality of life, and if you undergo a less expensive or a conventional treatment, how many days you are admitted in the hospital, you may not be able to go to job. So this is like daycare procedure. Patient comes, recently one of the patient came and asked me, sir, I want medical leave. So when I asked, okay, how many days you want? അല്ല സാർ, ഞാൻ ട്രീറ്റ്മെൻറ്റ് കഴിഞ്ഞ് അടുത്ത ദിവസം ജോലിക്ക് പോയി, ചെയ്ത ദിവസത്തെ മെഡിക്കൽ ലീവ് വേണം. അപ്പോൾ ഞാൻ പറഞ്ഞു അതിന് ഐ ടോൾഡ് ഹിം ജസ്റ്റ് ഷോ ദ ഡിസ്ചാർജ് സമ്മറി. സോ ദാറ്റ് ഈസ് ഓൾ ഹൗ തിങ്സ് ആർ ചേഞ്ചിങ്. So you should weigh how you should take into account the loss of pay you'll be accounting, all those things. So glue is after the cases what we discussed today, glue is of the little expensive, because the vial of the glue itself comes to around 1 lakh. So that is but you should know that it's a treatment which totally painless treatment, which does not need any anesthesia. It can be done completely under local, and patient does not have any scar, and immediately patient is mobilized after treatment. So other things, laser and RFA will be like much cheaper because it's cheaper, and the sclerotherapy is least expensive of all, because that medicine will be very cheap. But there are chances of success rates of laser, RFA and glue is the best as per the literature available. So you should always think, just because something is very cheap or least expensive, you should not offer that to your patient, because patient might come back again to you. So sclerotherapy I usually give to my patients like a combination treatment. In the few cases we saw, the laser we gave, along with that we gave sclerotherapy. Some patients of glue I give, where the glue doesn't reach, we might have to give sclerotherapy. Or when you call the patient after 1 month or something, you see all the tributaries, varicose veins, everything obliterated, but some varicose veins are existing, and if it's of a concern for the patient, you might have to do like a OP 1 hour procedure, half an hour procedure, like an OP procedure. You can give a sclerotherapy in combination. So I hope that is clear.
Congratulations, Tom, on the very nice presentation. And I am very happy to see that you are expanding your repertoire to various
Thank you, sir.
areas of the body. And for the audience, I'm very happy to say that our hospital is developing very fast into a major center for minimally invasive treatment of varicose veins. And there are multiple players, as you asked, in our hospital. Tom is taking the lead in this, and the cardiologists are doing the same thing, minimally invasive. And the surgeons also recently started minimally invasive treatment of varicose veins. They are doing endoscopic clipping or ligation of the perforators. So without a major wound, the surgeons also have started to do. So, any patients who Tom wants to refer after he's tried and needs to be dealt with by the surgeons, they also can do it through a 3 or 4 millimeter incision without making a major surgery. So I think our hospital is very gratifying to see that is soon developing, even though it's not well known outside, into a major center for multi-modal treatment for varicose veins. And my own sister was suffering from varicose veins and ulcers for many, many years. And she had a laser treatment 4 or 5 years ago. And she's absolutely happy about that after 5 years. So I can testify for this technique. Thank you.
Thank you, sir.
Will there be any recurrence for these newer procedures?
Yeah, ma'am, recurrence for varicose vein is for all the treatments of varicose veins, because the patient is active and walking, and theoretically any treatment you take, recurrence can happen down the year. There are studies which show 60 months, 5-year follow-up, 3-year follow-up, all those things can happen. So because you asked, I'll just show you a recent, it's another meta-analysis just for this old study which shows a 3-year follow-up of patients on how successful the treatment was. So you can see that out of this study, the best was endovascular. This is before the era of glue. After 3 years, almost 95% showed complete occluded varicose vein, whereas the patient who underwent vein stripping, only 78% patient had occlusion, successful occlusion. So that is before, theoretically any of the treatments can show recurrence, but that is why the patient has to be on regular follow-up. So patient has to be but if the patient gets ulcer treated, his skin changes disappearing, his symptoms, his or her symptoms, everything's disappearing, that is well and good. Maybe after 3 to 5 years, even if the varicose vein starts reappearing, and patients does not have any symptoms, they can be on follow-up, they can be on this conservative management also. Just that can in fact prevent the progression of disease. So once you treat it, patient goes home. It's not like patient does not follow up. Patient has to be in regular follow-up. Maybe initially once in 3 months, then maybe once in a year. Like any other disease, diabetes, hypertension, this is also important. So patient has to be on follow-up. That is.
If the glue is applied, what will happen to the vein finally?
So so basically, in stripping, stripping surgery, we remove the vein, ma'am. So glue, what we do is, it's just a principle different. In laser, we apply the heat. So glue, we just occlude. Basically, the vein, the damaged vein, dysfunction vein is the cause for the patient's symptoms. So we apply the glue and we occlude the glue. It's like a Fevicol or something, sticky thing. So vein will oppose each other. The vein wall will oppose each other. So
Permanent change?
yeah, it's a permanent change. It's a permanent change. Yeah. And we don't need essentially this varicose vein we don't need that to survive. That's why it's very important to document the deep veins are patent.
Actually, I am very proud because he is my classmate son, and I see ആദ്യം കാണുന്നത് ഒരു 9th class or 8th വെച്ചാണ് 95. So excellent, widen his horizons. I have got a reflection. You said one thing, deep vein thrombosis or deep vein, that you should document it. എല്ലാ ഡോക്ടേഴ്സും അങ്ങനെ ചെയ്യുന്നുണ്ടോ എനിക്കറിയത്തില്ല. ആൻഡ് കൺവെൻഷണൽ സർജറിയെക്കാട്ടിലും ലോസ് ഓഫ് പേ എന്ന് പറഞ്ഞു, ബട്ട് ലോസ് ഓഫ് ലൈഫ് ആയാലും എന്ത് ചെയ്യും? ബിക്കോസ് ലേസർ ട്രീറ്റ്മെൻറ്റ് ഞങ്ങളുടെ കോളേജിൽ ദർ ഈസ് വൺ ബോയ്, വെരി ഗുഡ് അനസ്തെറ്റിസ്റ്റ് ആയിരുന്നു, ഹർഷൻ. ആൻഡ് എനിക്ക് പരിചയം CMA വിളിച്ച ഹോസ്റ്റൽ വാർഡനായിരുന്നു. അപ്പം OT പിള്ളേർക്കൊക്കെ വളരെ നന്നായിട്ട് പാഷനേറ്റ് ക്ലാസ് എടുക്കും. ഹിസ് വൈഫ് ഈസ് എ ഗൈനക്കോളജിസ്റ്റ്. വെൻ ടു ട്രിവാൻഡ്രം കിംസ് ആൻഡ് ഡൺ ലേസർ ബിക്കോസ് ഓഫ് ദിസ് ഷോർട്ട് ആൻഡ് കെയിം ഹോം. ഹി വാസ് ആനെ പോലെ എലിഫൻ്റ് ഇങ്ങനെ കുഞ്ഞുങ്ങളെ വെച്ച് കളിക്കുന്നു, TV കണ്ടുകൊണ്ടിരിക്കുകയായിരുന്നു ആഫ്റ്റർ 2 days. ആൻഡ് പെട്ടെന്ന് എംബളൈസേഷൻ. ഞങ്ങളുടെ ജയകുമാർ കാർഡിയോതൊറാസിക് എല്ലാവരും വെൻറ്റിലേറ്ററുമായിട്ട് വീട്ടിൽ ചെന്നു. ഹി ഡൈഡ് ആക്ച്വലി. ഹി വാസ് ദ ഒൺലി സൺ. ഞാൻ ഡോക്ടർ കുഞ്ഞമ്മ എല്ലാവരും അടക്കത്തിന് പോയി. ബട്ട് ദാറ്റ് ഈസ് വെരി ഇപ്പോഴും ഞാൻ ഓർക്കാം. ഇറ്റ് ഈസ് 10 years ഒക്കെ കഴിഞ്ഞെന്ന് തോന്നുന്നു. ചെറിയ പരിചയം, ബട്ട് ഹീസ് എ വെരി ഗുഡ്. ഇച്ചിരി വണ്ണമൊക്കെ ഉണ്ട്. ആൻഡ് സോ ദാറ്റ് ഈസ് ലേസർ ട്രീറ്റ്മെൻറ്റ്. വെദർ ഈ ഡീപ്പ് ആൻഡ് യൂസൈഡ് ഓൾ ഷുഡ് ചെക്ക്. ഓൾ ആർ ചെക്കിങ്. സോ കൺവെൻഷണൽ സർജറി ആണോ ഇച്ചിരി വെയിറ്റ് ചെയ്താലും നല്ലത് എന്നുള്ള ഇതുണ്ട്. പിന്നെ നമ്മുടെ ചുറ്റും മടുക്കുകയാണ്. കഞ്ഞിക്കുഴി മാങ്ങാന സ്ഥലത്ത് ഞങ്ങളുടെ സോ മെനി ആർ ഗെറ്റിംഗ് ദീസ് റെക്കറൻസ് വരുമ്പോൾ അവർ പിന്നെങ്ങും പാതി ഇതുപോലെ പ്രിമിറ്റീവ് ട്രീറ്റ്മെൻ്റ് ഒക്കെ ഇടും. സോ വാട്ട് അവെയർനെസ് വി ഷുഡ് ഡു.
Thank you, ma'am. So, ma'am, about the what specific case you told, I don't know about that case. What happened in that case? So, essentially, there have been some disastrous complications for all the treatments. If you take any treatment, if you are like for any treatment, if you are not very careful, certain complications can happen. So, establishing the deep vein is patent is very important. But let's say if the laser is being ablated, if it goes into the deep vein and ablate, obviously patient can develop other disastrous complications. So, yes, sir. Yes, sir. So yes. So that is why we actually, in fact, we entertain all our patients early mobilization. We don't recommend any rest, like if it's a glue treatment, it's a local anesthesia. So it's like we get any procedure under local anesthesia. Immediately patient can. Mobilization is very important. That even if it's under mild sedation, maybe we will mobilize after 1 hour. So, and we don't know whether their patient has any underlying other vascular disorders for that particular case. Also, we don't.
Thank you, Tom, for that very good presentation. It was very informative, because this is a condition which everyone comes across, may not be as a patient, but somebody coming to you with this problem. So it was very well addressed, and I've seen how it has developed, the journey that has been there, right from prevention, like how you apply the crepe bandage, followed by, if it is a surgical procedure, sclerotherapy, venous stripping, Trendelenburg procedure, and it goes on. And we have reached this interventional radiology, which has come to such an advanced state, and really good that you're doing a wonderful job. And how many years follow-up do you have, the maximum? You mentioned 3 years. So what is the latest paper on the follow-up? How many years study is that?
No, ma'am, that is one, just because ma'am asked, I just showed you one of the studies. There have been studies showing 66 months studies, or like basically 5 years study.
Okay.
That is just to compare each method of treatment, ma'am. Ideally, the patient has to be like, it's not like patient has to at least see you once in a year, or maybe like at least once in 2 years we should be following him. Because once you, like there are methods how you can, when you follow up, you classify. There are studies which show how on follow up, like after like 5 years or 3 years, when the patient comes, how is the occlusion? Whether the vein can be still completely occluded. The vein can be occluded partially. The vein may not be, the occlusion is completely recanalized, but the reflex is stopped. So, but there can be the reflex. That means a recurrence. Okay. So you can classify your patients and then keep them under follow up. If it is completely occluded, well, maybe the interval follow-up can be like more for. But if there is a recurrence, then obviously then the patient, we don't want the patient develop an ulcer again. Then you have to suggest, if you have to tell them, yeah, you had undergone treatment here, or you had undergone treatment in another center. Now you have a reflex, and there is chances for the venous hypertension to develop, and so there is chances of chronic venous insufficiency. So he or she needs a treatment.
So the greatest advantage is it's a daycare procedure where the patient can go home. There was a time we used to give, even now it happens, whenever this facility is not available, this procedure has to be done either under spinal anesthesia. If both the limbs are involved, even an epidural has to be placed, some epidural catheter, which means you need to keep the patient for more than maybe for 48 hours or depending on that. And a lot of follow-up and the compression bandage, everything is there. So the duration of stay in hospital definitely increases. So from that level, we have come to this stage where interventional, where you're doing all these endovascular procedures. Only thing is a cost factor. Maybe that is one thing that is preventing patients from coming to this for this procedure.
Yeah.
Now you had
And
projected.
patients who have insurance, all these will be covered under insurance. That's another query the patients ask, whether this
Yeah.
is covered. That's another thing patients ask.
So even here there is minimally some. So we have to do it under conscious sedation, where we have excellent medicines available like dexmedetomidine infusion as something which is really good, where you can keep the patient under sedation but he'll be awake. So there won't be any problem of respiratory depression or anything happening, which is a safe procedure. We would give the infusion, which is very good. And one query I had, that is nothing to do with the, I don't know whether you had projected a picture of the spider vein and the reticular vein. Sometimes someone known to you might just ask, I have such a thing on my leg. So what has to be done? Is it varicose or what is it?
Yeah.
It is quite, for some people you've seen, it's like a network over the skin, which is quite visible. So what is it that you would?
Yeah, ma'am. Basically, there's a from the place to place, these things can vary. Basically, in our country, like compared to Western, we usually come to the doctor. This is a very rare scenario of an Indian setup. In our scenario, patients will come and tell, varicose, but patients will usually come towards when they are frank, non-healing ulcers. Abroad, because the patients, they are like cosmetically little more concerned. Obviously, I'm just not comparing country to country. They usually, because and their the dressing style also is different. Wherever there is exposed area, they need it to be treated like a cosmetic of an urgent concern. So coming back to your question, so basically that is, if you want it to be treated, it is not a definite like urgent situation to treat it. But if you want to be treated, the locally that doesn't obviously need a major procedure. A local sclerotherapy can be done.
Okay.
That can be done, and that veins can be treated.
Does it progress to varicosities later on?
Ma'am, if there is an underlying, you have to look for an underlying major varicose, underlying diseased varicose vein. Then, if you can find that, then you might have to treat that. But the patient has to be on follow-up, ma'am. Yeah.
Thank you, ma'am. Thank you all. If there are any more questions, you can ask Dr. Tom directly. Dr. Tom, we were all glued to your talk, and we hope that your efforts will never go in vain. So, on that note, thank you so much. Let's give a big round of applause to all that Tom, path-breaking stuff that Tom is doing, and we wish you all the best in all that you do. So, thank you all for coming. Have a wonderful day. Thank you.